Good evening, everyone. I'd like to call the Budget and Finance Committee meeting of the Central Health Board of Managers to order. It is 5:30 p.m. on Wednesday, July the 24th. Welcome to all and our visitors. As a quorum of the committee is in attendance, I would like to again formally call to order the meeting of the Central Health Board of Managers Budget and Finance Committee. Items 3, 10, and 11 will not be discussed tonight. And those items are, number 3, discuss and take appropriate action on the use of new initiatives funds during fiscal year 2019, including an agreement with Social Finance Incorporated and its subsidiary PAATH LLC for permanent supportive housing and wraparound services to be provided to homeless Travis County residents. Item number 10, discuss and take appropriate action on healthcare service delivery expansion in eastern Travis County, including project budgets. And item number 11, discuss and take appropriate action on Central Health owned and occupied real property and potential property for acquisition or lease, including the downtown campus and properties located in eastern Travis County. With that, we will take the agenda in the order it is written, noting the exception of those items that we will not take up. And I'd like to lay out item number 1, consider and approve the minutes of the June 12, 2019 meeting of the Central Health Board of Managers Budget and Finance Committee. Do I have a motion? I have a motion from Ms. Valadez, and I have a second from Ms. Greenberg. Any?
Oh, yeah.
I have to use my words.
Yes. I move that we approve June 11th, June 12th, 2019. Second.
I now have a formal motion from Manager Valadez and a second from Manager Greenberg. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Agenda item number 2, receive and discuss an overview of the proposed healthcare provider participation program to be administered by Central Health, including a proposed mandatory payment rate to be assessed to each institutional healthcare provider located within the boundaries of Travis County for a local provider participation fund pursuant to Chapter 298E of the Texas Health and Safety Code. And presenting this will be Katie Coburn and Jeff Knodel. Welcome. And
thank you. Good evening. Thanks for introducing us. Jeff Knodel, Katie will be doing the presentation. This is an item related to the local provider participation fund. We're actually here tonight just for informational purposes only. We'll be coming back next week to request action related to setting the rate for the LPPF. Just quickly recapping, previously at the last board meeting, Central Health approved the establishment of the LPPF. The next logical steps as we move forward is actually setting the rate that the mandatory rate that will be collected through the LPPF. Central Health is the administrator of the LPPF for the legislation that passed. And with that, I'm going to turn it over to Katie.
Sure. Good evening, everyone. I'm Katie Coburn. And as Jeff said, we're going to update you on where we are in getting the LPPF for Travis County off the ground. As we explained to y'all last month as you adopted the resolution that created the program, we needed to do that quickly because Central Health, or the LPPF itself actually, and Central Health as the administrator, needed to enter into affiliation agreements with hospitals so the LPPF funds could be used for the September UC payment. Those affiliation agreements were due July 15th, and I'm happy to report we got all of those in on time. So the fund will cover those payments. We've also been working, kind of on the back house side of things to set up the required bank accounts for the LPPF, the TextNet account, which is the process we use to actually transfer the funds to HHSC, and all those administrative details. And we have received a mandatory payment rate proposals from the hospitals in Travis County, and we're going to talk about what that looks like tonight, and we've been negotiating with them and talking to them about what's entailed there. So we'll talk about that. These are the affiliated entities that are affiliated with the TCHD LPPF, which is what we're calling it. And again, these facilities, Central Health was already affiliated with. Now the LPPF can also apply to those transfers. We also now have some new facilities, in particular Universal Health Systems over there on the right. New facilities that are now affiliated with the LPPF only in our community for this program. And again, this is who is affiliated now. That can change from time to time, and we'll keep you updated with that. So as Jeff mentioned, we're working now on setting that initial mandatory payment rate. And just as a reminder, that rate is assessed on the net patient revenue of all the Travis County inpatient hospitals. That rate is set by you all, the Board of Managers, officially. And then Central Health, as the LPPF administrator, we collect the funds from those mandatory payments and we hold them in a fiduciary capacity and then complete intergovernmental transfers with those funds on behalf of the hospitals. The use of the funds is limited to what's laid out in the legislation that authorized the fund. In general, it's for anything that can for supplemental payments, that can draw down federal matching funds. And Central Health, then we have been, as I said, we've been collaborating with the hospitals to determine what the official use of the funds for this payment rate will be and what that rate will be. And the initial rate will be set next week by you all. So what the hospitals have proposed is a payment rate of 1.11% on the net patient revenue, which would generate about $35 million in local funds to be used for those IGTs. This amount is designed to be sufficient enough to generate the local portion of the September UC payment and the November Uniform Hospital Rate Increase Program, which is an additional supplemental payment program that hospitals have access to. It helps increase Medicaid payment rates for hospital care. So what to expect next week? As required by the legislation, the Board of Managers holds a public hearing to consider the payment rate. We will be finalizing our recommendation for what that payment rate is in collaboration with the hospitals and bringing that to you all in advance so you all can have a final rate to consider. We will be asking you to consider and adopt a resolution that does three primary things. It sets that mandatory payment rate. It designates the depository bank for the LPPF fund that's required in the legislation, and then delegate administrative duties to actually administer the fund to the CEO. There are other administrative functions for the LPPF that fit in with our Central Health other financial responsibilities, such as an investment policy when we need to hold the funds, what we do with those, what collateralization looks like. So we'll be asking you all to take a look at that next week as well. And then just a recap of our timeline. You can see we've gone through those June and July dates. Next week is our public hearing. On September 9th, we will be transferring those LPPF funds for the uncompensated care payment, as those are called for by HHSC. During October and November, we will be collaborating with hospitals and working with you all to set the next rate for the LPPF program to cover additional payments as we go forward in that process. So the rate setting is at least an annual process generally, and so the next one will be coming up this fall. And And then in November, we expect to transfer the funds for the Europe program. And that's where we are today. I'm happy to take questions.
Thank you very much, Katie. I appreciate it. As Katie stated, we are not voting on this item today. This is for a resolution for next week at our board meeting. Do we have any discussion? Julie.
I just have one question. I noticed that there are some non-Travis County hospitals, and I get that it's a tax, so it is what it is, but any reason there are non-Travis County hospitals as part of this?
I think the main reason there are non-Travis County hospitals has to do with what's going to happen later when the uncompensated care payments are then distributed through the service delivery area, which is an 8-county region surrounding
Got it.
Travis.
Yep, thank you.
Can I just have
Yes,
one
Ms. Valdez.
do y'all have an idea as to what the other administrative rates are in other districts that have been doing this for a while, whether it be in Texas or in other areas?
I think it depends. They are not, 1.11 of the ones I've seen seems actually lower than a lot of them.
Yes.
Sometimes they're a little bit higher. And they do change from time to time. As an aggregate, it can never go higher than 6% of the net patient revenue of a hospital, of the aggregate of all the net patient revenue in the county. It can't go higher than 6%, but I've never seen one close to that.
Do you have a feel for how many, is there a chart that looks at, okay, in this district, this is what it is, in this district, this is what it is?
We could look to provide that.
Yeah.
It's
So that would
really-
give us as a board some.
It's really about sizing what the requirements are for the programs.
For the
And
hospitals.
remember, it's a percentage of net patient revenue. So from a math perspective, you kind of have a couple elements that to some degree aren't in your control, and then that drives the rate. But we'll be more than happy to try to research and
That would be, I think.
get some of the rates. Sure.
Ms. Oliver?
Are we subject to any of the haircut provisions like the old UC program? I mean,
Yes.
so that there's just a chunk of the pie and we get it, depending on how many people participate. So we're subject to all those haircuts
That's
and all those old things as well. Okay, got it.
Yes. Yeah, that doesn't go away.
Any other questions? Thank you very much. Appreciate it. Agenda item number 4, receive and discuss a presentation on the proposed Central Health and Community Care Collaborative Fiscal Year 2020 budget. Presenting will be Jeff Knodel, Lisa Owens, and John Morgan.
Okay, thanks. We will go through the presentation related to our fiscal year 2020 budget. I'll say right offhand, there are, as you noticed from the last item, there are a lot of changes that are undergoing this year. In fact, at some point, I'd almost call it the year of changes related to fiscal year 20. So lots of changes going on. We're not going to be presenting a budget where tonight where here are all the budget numbers and you can look at everything and see what we're proposing. We hope to bring something in that format next week. So what we wanted to go over tonight was really talk about some of the changes that you would see next week. Do an overview related to the property tax rate, and actually do see a few numbers related to the capital budget. And then Mr. Morgan's going to tell us about healthcare service delivery, some of the highlights that we have upcoming, knowing that we'll have plenty of time in subsequent budget sessions to get into some detail related to those services. So when we talk about our budget, we always want to be aligned with our strategic plan. So I've listed out some of our strategic objectives related to our strategic plan. looking at developing and executing healthcare delivery based on people in place, implementing patient-focused and coordinated healthcare, and developing sustainable healthcare financing models. So we've listed out a few things. It's certainly not limited to our strategic plan, but just a few things that relate to our strategic plan as we start talking about our fiscal year 2020 budget. I just want to make sure I state that there's a lot of things in this budget that you'll see over the next couple of months, and I don't want to feel like I left anything out, but I just listed a few there on this slide. So this slide is, I borrowed this slide from Lisa Kirsch, who was with HHSC. She was an associate commissioner, I believe, and it resonates in a way that I think is important for us at Central Health. The title of it is How We Pay for Care Impacts How Care is Delivered, and I think that has certainly been evident, you know, throughout the healthcare system, throughout the healthcare industry. Financing healthcare can place limitations or disincentives on how care is delivered, and can be limitations to the effectiveness and efficient delivery of that healthcare. So we've talked about a lot of changes that are coming forward as far as how we fund healthcare, and I just want to state that we're trying to keep this in mind as we move forward, that we do want to set up the right structure so we incentivize the right kind of care that we deliver to our residents in Travis County. So we're trying to keep this in mind, and you know, from a financing standpoint or from a payment perspective, we just want to make sure that we're aligned with how we want to deliver services related to the community. So speaking of financial models and how things are paid for and delivered, just a quick reminder related to our current funding model, which is a indirect funding model for hospital services. So the actual funding model is governed by the master agreement and the services, the omnibus services agreement that was executed in June of 2013. And in that agreement, there are two elements of it. One element is the obligation for Seton to provide a level of hospital services and some limited specialty care services related to 2013 levels. And then the next element of it is how those services are paid for. And those are generally paid for through intergovernmental transfers or IGTs related to those services at hospitals through the uncompensated care program and the disproportionate share program. Oops. So as we start talking through and walking through some of the changes in fiscal year 20, we've talked some in previous meetings, but I'm going to take just a second to kind of go back over some of these. There have been a lot of changes in uncompensated care. Beginning next year, October 1st, or in October the next year, the payments that have previously been distributed through what are called directed intergovernmental transfers, or funds that are provided locally and go to specific hospital facilities, that's going to change, and those payments will begun to be distributed to hospital providers across the 8-county Medicaid service delivery area. So that's a big change related to how those funds are distributed. The second change, or one of the other changes, I should say, you just heard related around the LPPF and how the hospital payments will actually provide local funds related to the uncompensated care in the Europe program. There's also have been some legal guidance related to just public or nonprofit private entities in the what are called DAB decisions, which stands for the District Appeals Board. It's a part of HHSS. And those decisions were handed down in Dallas and Tarrant County, I believe in August of last year. And then last, but certainly not least, is Central Health is negotiating a change from the indirect payment model that we just talked about the last slide to more of a direct payment model for hospital services. So there'll be plenty more to come on this, hopefully in subsequent meetings, but these are still very preliminary negotiations, and I think we're scheduled to talk about this later in our meeting in closed session. So I just wanted to mention that we're negotiating these changes. At this point, they're ongoing negotiations. And then certainly another aspect of it are the legislative actions that occurred recently. And again, the LPPF, the creation of the LPPF, which you've approved the creation of it, was an element. And then the Central Health bill that allows Central Health to practice medicine was another legislative action. So specifically related, without getting into numbers, some of the fiscal year 2020 changes that you will expect to see or may see related to changes on the Central Health side in healthcare delivery. Typically, we have a pretty robust budget related around intergovernmental transfers. That's going to be a little bit different this year. We'll have budget for disproportionate share and the CCC Deseret projects only. So remember the LPPF that you just approved and that we're looking to set the right next board meeting, that that's the funding source for uncompensated care, and that typically has been the largest program that Central Health has funded. Funding for a majority of the healthcare delivery cost will be in Central Health. And then, as I mentioned earlier, as we negotiate around hospital services, we're hopeful again that we would see a budget line item related to hospital services that are more direct in nature. And then on the community care collaborative, budgetarily speaking, you'll see Deseret revenue and Deseret project cost. You'll see the budget for the University of Texas Dell Medical School affiliation payment. And then you'll see some limited healthcare delivery cost related around the CCC. So I'm going to turn it over to Lisa and have her, she's going to continue the presentation.
Thank you. Good evening. So as Jeff mentioned, we did want to talk about two areas where we have some numbers, although they're very preliminary, and that is going to be our tax revenue, which, as you know, is our primary source of revenue. It is based on the taxable assessed values that we receive from Travis Central Appraisal District. Our current estimate, which is very preliminary, and we may not receive the final estimate until late August, is that the valuation is around $208 billion, which is over a $20 billion increase over last year, and about 25% of that is new construction. So that, combined with the effective tax rate and drafting the budget at 6.3% over the effective tax rate, you'll see the tax rate actually go down as the assessed values continue to rise. And this chart shows the trends that we've continued to see with the market continuing to do very well here. It does generate additional tax revenue. However, as a result of the new construction and increased in assessed values, we do anticipate about $17 million in new tax revenue. We shared this slide with you in our previous presentation at our June Budget and Finance meeting. We are drafting the budget with 6.3% over the effective rate. This shows our 7-year sources and uses of funds, and as a reminder, we want to get to that FY26 point, so we took it out to 7 years. That shows that we're structurally balanced and the sources and uses are equal. And then that also starts to show that with all the changes in 2022, 2023, we are beginning to recover, and that our reserves are stabilizing and starting to slightly increase again. Again, we like to have the goal of 100 days of cash on hand. This shows that we would be getting into a better position as we move into 2026, with that starting to go back up towards 100. And as I mentioned, again, our very preliminary estimates are looking at another additional increase of around $17 million in tax revenue. So another area that we're going to bring more details this year is a capital plan, long-term capital plan. In years past, you've seen the budget for the capital reserves for that year. But as we've been talking about expanding services in Eastern Travis County, this year we've started significant investments in the campus redevelopment and in Eastern Travis County in clinical services. We anticipate that the capital planning on a longer term is going to be key to this board making decisions and investments. So I've drafted a longer term plan here for you. It's broken out by the main categories of clinical service investments, campus redevelopment, technology and equipment, and then facilities and operations. And then it just will start to show you where, as things become more formalized or projects are approved to move forward, where we might fund those from. So right now we have some sources of funds being cash and some sources of funds being debt. Debt could be in the form of a line of credit, which we've talked to the board about in the past and we hope to bring forward through the budget process, or it could be a specific debt issuance through bonds for larger projects. So what we're showing you here, we don't have specific projects identified because those have not been approved by the board, but this is just an estimate of some of the investments that are being talked about that could come into fruition in the next few years, and that we would need to consider how we might fund those. It could be, and this is very conservative, in the form of issuing bonds or a line of credit, or it could be through cash funding. So this is just a preliminary look at what additional details we'll be bringing in the budget. And then I have a slide that shows kind of what we're looking at in 2020, which you'll start to see more formally in the budget document. As you know, we keep a capital reserve. Right now it's about $7 million. That is for specific projects that have been started or we think will be starting in the upcoming years. We estimate with the campus projects and the Eastern Travis County projects this year that we would start the year at about $3.8 million in that reserve. Again, just the timing of some of the projects, we don't know when they will start. We would carry that forward, and if this, again, is a list of assumptions, this would be a lot of great projects starting all at once. But if we had 2 to 3 potential clinic locations that were significant, start to have construction needs and infrastructure, that is an assumption in there. We do think the Red River realignment will be happening in the near future. And then clinical software and services to support our enterprise partners is always a critical component to access. And then finally, just the facilities and operations would include building and improvements on some of our existing locations where we may need some just building improvements. And there's also, unknowns. We may have a need at a clinic or at an administrative office that arises. So this is just a look at what that could look like. Again, we'll bring you much more detail in the budget process. So as the presentation continues, I think we're going to focus on some accomplishments and strategies. Turn it over to John Morgan.
Thank you, Lisa. Good evening, I'm John Morgan, I'm the Executive Director for the Community Care Collaborative. I've got the pleasure this evening of being able to highlight a few of the successes of our collective organizations in terms of improvements to healthcare delivery over FY19, and then also introducing some of our focus areas and new initiatives that we have planned going into FY20. Before I dive into this, I have to acknowledge that nothing that I'm going to talk about today would be happening at all if it weren't for our extremely dedicated staff, both at Central Health and the CCC, as well as our partners and contracted providers. I mean, nothing that we do here we do by ourselves. So I have to start with just acknowledging all of the efforts that come together to make this work happen. We've chosen tonight to focus on 3 specific areas in healthcare delivery and to talk about both the accomplishments and the upcoming highlights. Any of these items I talk about could be a 15 or 30-minute presentation on its own, so I'm going to hit the very, very high-level highlights, and then we'll continue to bring back additional detail and be able to answer questions as the budget process continues. I think you all are very familiar in primary care with some of the work that's been happening in Eastern Travis County, including the mobile clinic that Community Care started operating about 4 weeks ago in Creedmoor and Colony Park, as well as the recent announcement about land acquisition in Hornsby Bend. So making good progress with our partners and bringing additional services online in Eastern Travis County, with Community Care really leading the way there. As well as in these other areas similarly to Eastern Travis County, this is really for us about improving access to care through a variety of mechanisms and a variety of methods, and making the most appropriate level of care or site of care more accessible to our patients. So MAP Basic is another part of us expanding access to care. We launched the enrollment to that program in April of this year. As of today, we've got about 13,000 folks that have been enrolled in that program, which is 20 or 25% ahead of schedule for us. And we expect by the end of the fiscal year, we'll have about 25,000 people that were formerly in different sliding fee scale programs enrolled in MAP Basic. And we'll talk a little bit more about what that means in terms of the benefits to the patient further in the presentation. We continue to grow in terms of the services we provide and the number of people that we collectively serve. There are more people enrolled in the MAP program today than there ever have been before. This year we are averaging, at least in June and July, about 30,000 MAP enrollees, which is more than we've had in the past. So that's about 12% higher than we had 2 years ago. We're also projecting to provide more services in many of the areas of service delivery that we provide. We'll have more definite projections for you in future presentations, but both services and enrollment into our programs has been increasing year over year. Urgent care, as you know, is another mechanism for us to bring after hours access available and an alternative for our patients to going to the emergency room. We're continuing to use that as one of our strategies going forward. Today we have 19 facilities in network for our MAP patients, as well as the Ascension Connect digital urgent care platform through our partners at Ascension Seton. Important to note, we've made significant improvements in clinical outcomes for our patients over the past few years, some related to our work in the DSRIP program, but also through our pay-for-performance mechanisms in our primary care contracts. As a reminder, working with Community Care and Lone Star Circle of Care and Hospice Austin, we had significant success in the DSRIP program for calendar year 18, achieving 95.3% of the available funding, or about $63 million that we've earned through participation and performance in that program. More importantly, that means we improved 32 out of 36 clinical outcome measures for the patients in our system working through our partners. That translates into increased screening rates, increased vaccination rates for flu vaccines, for HPV vaccines, and then the last item you'll see on this list is related to fit testing. So far this year, our efforts to increase our colorectal cancer screening in our population has gotten access to that screening for about 1,500 patients this year, just this year, that may not have had access to that service before now. Overall, that translates to increasing our colorectal cancer screening rate in our district population from about 26% 2 years ago to more than 45% this year. Certainly, again, with community care leading the way in that effort. Moving to our next slide, specialty care is the second area that I'd like to highlight. Just a few of the accomplishments of our staff and partners. I shared an email update a few weeks ago, so some of this may be reiterating a few of those points, but we're happy to announce that we've working over the past 2 years with Austin Regional Clinic, have been able to clear the MAP wait list for ENT services. That's been a huge effort and a great partnership with Austin Regional Clinic. Similarly, after adding iPhysicians of Austin to our network, we've been able to clear the MAP wait list for ophthalmology as well. And these two are really good examples of one of the strategies that we try to put into place in specialty care, which is engaging with provider organizations that traditionally haven't worked very closely with the safety net system. So we're happy to have both of these provider groups working with us to address our needs. Another strategy that we have that the next two bullets here will highlight is really trying to build specialty care capacity and expertise in our primary care settings. So for both wound care and rheumatology, community care has worked to bring both of these services online and expand access to wound care and rheumatology for our patients. Wound care is expected to start in August of this year with a full-time wound care nurse at the Care Connections Clinic, which was formerly the Seton Kosmetsky Clinic. So bringing wound care services online for some of our more complex patients and our homeless patients that utilize that clinic, as well as rheumatology services through a full-time rheumatology hire and the development of a subject matter expert model with some of our primary care providers starting to manage some of the ongoing rheumatology issues. That rheumatology effort has resulted in a 20% decrease in our wait list since Dr. Shapiro started a few months ago. General surgery is something we'll continue to talk about as we move into FY20. This is another community partnership, new community partnership with Austin Surgeons. We've designed a pilot with Austin Surgeons to try to take people out of the wait list that are eligible either for office-based procedures or surgeries in an ambulatory surgery center and expand access through that mechanism. It's still very new, but it is live. All of those, that series of agreements have been executed, and our first round of patients were seen just last month. Substance use programming, you all are familiar with the services that SIMS provides to our patients, as well as our medication-assisted treatment program for opioid use addiction. These programs have both been very successful. With the MAP program in particular, we've had 161 MAP patients enroll in that substance use treatment, that medication-assisted treatment pilot. We're now at the point that we're starting to see our MAP patients actually graduate from that program. It's a 12-month-long program, and we're fortunate that we've actually graduated 13 patients out of that, and we're going to continue to make that service available. Physical therapy is another area of significant expansion this year. We went from having one location in partnership with Texas physical therapy specialists to now having access to their entire network across Austin and Travis County. And we're projecting at this point to have about 5,000 physical therapy visits for around 700 patients by the end of the year. And again, these are services that before this year would not have been available to this extent. The final area I'll talk about in terms of accomplishments is something that is relatively new. Our medical management program is something that we've started just in the past couple of years through the CCC. There are a few things that we do there, and I'll try to summarize them briefly. One is developing the continuum of care for the post-acute care services that have largely been absent from our system. This consists of skilled nursing facilities, home health, palliative care, hospice care, what we've added in terms of medical respite services this year. These services that help us transition our patients out of hospitals and into more appropriate locations for them to recover from those acute stays. And the second thing that we really do in medical management is construct care teams around our our most complex patients so that we can help navigate them through the system. This is taking a hands-on approach to the navigation of our patients that are coming out of a inpatient environment and transitioning them back to primary care. And also, we have teams that consist of a nurse, a social worker, and a community health worker that together address the needs of our most complex patients. In general, we have about 150 of our most complex MAP patients in that program at any given time. And they are really helping with everything from home-based case management visits to navigating those patients to medical appointments and helping them to connect the dots. I mentioned home health and residential rooming services. Home health, we were able to partner with Gilead this year, in March of this year. That's been a great service to add to the array of post-acute services that we provide. Now we're able to send home-based physical therapy and wound care to our patients instead of having to bring our patients to the care. Residential rooming is expected to start in August. This is the medical respite that we've talked about, providing a place for our homeless enrollees to recover if they don't have a skilled medical need, but they're still just not in a state that they should be discharged to the streets. Finally, hospice and transportation. Our hospice program continues to grow. We've got about 100 patients, 100 MAP patients that use that service every year. That equates to about 2,500 home visits for our patients enrolled in the hospice program, as well as over 120 patient days a year in the Christopher House. The big difference there being that our MAP patients now have the same access to hospice services that those of us sitting around the table have. They're not restricted to a very limited charity bed access. And then our transportation program, there are multiple out there. What we've done this year that I would highlight is through a rideshare pilot. I think you all are familiar with the Ride Austin rideshare pilot that we started. We've continued that work and provided around 1,200 rides this year, again, to our complex patients for being able to access medical services, pharmacy services, and benefits enrollment. That's a program that we are continuing to build. We're in the process of executing an agreement just in the next couple of weeks to transition to a third-party platform that'll really enhance our capabilities and make ride scheduling a lot more efficient. These next three slides I'll do very quickly. I'm just going to lightly touch on these initiatives in the same three areas of primary care, specialty care, and medical management to give you an idea of what you'll see in the upcoming budget discussions, not in a lot of detail. I mentioned the rollout of MAP Basic. As we're rolling that out, we're also enhancing the benefits that are available. You'll probably remember that the major benefit that was added as we developed MAP Basic was the pharmacy benefit, having the same MAP formulary pharmacy available to our patients that were formerly in sliding fee scale as a standard benefit. Pharmacy we know is excuse me, I skipped ahead. The two things that we're looking to add to MAP Basic as we go into FY20 is adding urgent care and adding screening mammography as benefits of the MAP Basic program. So that we're trying to round out this basic primary care benefit that we think should be available to all of the patients that we cover. Pharmacy we know is a critical aspect of our benefit structure. It's a large part of our ability to help our providers keep our patients healthy, and it's often a limitation on access to care for our patients. So for pharmacy, we're really working to expand access, make sure that we're using that program as efficiently as possible, which includes maximizing use of the 340B program and also drug manufacturers' prescription assistance programs. You'll be hearing a lot more about pharmacy in the budget process. We're also looking for ways to expand access to HIV-related treatments, both the pre-exposure and post-exposure services in the system. That's something else we're going to be adding this year. And then Factor Health is a new initiative you may not have heard much about. So Factor Health is a collaboration with the Dell Medical School with funding support from the Episcopal Health Foundation and partnering with Meals on Wheels to develop nutrition-specific or customized developed meal plans for some of our medically fragile patients, where having the right nutritious meal is critical to them achieving their health outcomes. So we're really looking at patients that are being discharged from the hospital who need access to have specific dietary needs and have food insecurity, and working to pilot that over the next 2 years at no cost to us. This is what Episcopal Health is funding as a pilot for 2 years. The medical school is bringing expertise and evaluation to the table, and we are helping guide them in terms of which patients we think are eligible for the program, which patients will benefit from it, and then if after 2 years we're able to demonstrate the outcomes that we're looking for, we would continue to fund that program in the future. Medication-assisted treatment program evolution is really about iterating the model that we've started in collaboration with Integral Care and Community Care. We're trying to continue to serve those patients in primary care settings that allows us to conduct more inductions through the actual core model. So we're expanding the availability of that opioid treatment into the primary care setting so that we can grow the capacity of who we're treating. In specialty care, you all have heard a lot about e-consults. It's been a multi-year effort. I'm happy to share that our joint RFP process has concluded, and we have a finalist that we're now entering negotiations with. So we are still on schedule for completing contracting over the next couple of months, and then starting to implement an e-consult platform towards the tail end of this year. The e-consult and referral management platform is really going to fundamentally change how we do specialty care in the safety net system. Today, it's disjointed, it's manual, and there's not good data tracking, and we don't have the ability to really connect our primary care physicians with the specialty expertise that they need to take care of our patients. So this is really going to put that knowledge in the hands of our primary care providers and create efficiencies and tracking mechanisms throughout our specialty care network. Nephrology is an exciting initiative in specialty care. This is a new initiative where we have participated in the joint hire of a nephrologist who should be arriving here in Austin in the next few months. The unique thing about Dr. Novick is she is both a nephrologist, medical doctor, and a social worker. And she was a social worker previously working with dialysis patients and went to medical school. So we have a really unique opportunity to bring her expertise to Austin, to expand access to the renal clinics that we have, to have her participate in our e-consult solution and bring that expertise into our primary care setting, and also to help us start thinking about and designing what a dialysis solution would look like for our patients for a few years out. Gastroenterology continues to be one of our highest areas of need. We've got multiple initiatives planned in that space, and we're going to continue to focus on it going into FY20. Just in the past week or week and a half, we executed a series of agreements that will allow us to bring a new gastroenterologist into our network, Dr. Reddy, as well as the North Austin Surgery Center, where we can do colonoscopies and EGDs for patients that need it. So we'll be continuing to work through the process of operationalizing that work, as well as working with community care, Ascension Seton, and the medical school on additional gastroenterology interventions next year. Dermatology, there are also several ongoing and planned interventions, a multifactorial approach to how we're going to eliminate our dermatology wait list. It starts with MA and nurse-led camera clinics inside of community care that then go to an Ascension Medical Group dermatologist that does an e-consult or a dermatologic triage process that helps direct patients to either a clinic follow-up or to a procedure clinic as needed. We're also adding 5 additional half-days of dermatology clinic inside of community care through a joint Seton and community care hire, So that's very exciting. And we also have a expansion effort underway with ARC. So Austin Regional Clinic, following our successes with the ENT work, is going to work with us to also expand the availability of dermatology services. Finally, and I think I'm almost done here, podiatry is another expansion effort inside of community care. Community care is right now recruiting for that position, and we hope that those services are brought online towards the end of this year and really ramping up in FY20. My final slide, I spoke in detail about the care management team model for FY20. This is really about evolving that model, that nurse, social work, community health worker model, so that our complex patients that are either in transition or maybe falling through the cracks have a resource. We can go into people's homes and help them navigate the system, as well as continuing to build out our post-acute program. Again, we'll talk a lot more about this in future presentations. I do want to call attention to one of the activities of our medical management team that is just a big impact on our patients. One of the things that our social workers do today as part of their routine schedule is helping to identify patients who may be eligible for other coverage, whether that's disability or whether that's another third-party funded program, and they help get them enrolled into those programs. So what we're proposing as one of our initiatives is to turn that from a part-time effort for each of our social workers into a dedicated position to help our MAP patients who are eligible get enrolled in disability. That'll get them access to additional levels of Medicare beyond, or medical services beyond what we can provide. Just this year, we've enrolled 34 of our MAP patients into disability and another 21 into commercial health plan coverage. Those 21 being patients that were in end-stage renal disease. Getting them access to commercial health care coverage also gets them access to routine dialysis that's currently not available to our patients. I think I'll turn it over to Lisa, and I'm happy to answer questions at the end.
Okay, just a few more highlights of accomplishments that we will continue to see as we go from FY19 to FY20. And again, I would echo John in praising the enterprise staff for these accomplishments. It truly is the work of our frontline staff and key community engagement efforts that is really exciting to share with you. There was so much community outreach and engagement. I didn't provide bullets, but as you have seen, we've made significant investments in things like community conversations and continued success with our community health champions programs and community engagement, and that will continue as we go into FY20. Our Central Health Equity Policy Council has a policy initiative that is moving forward for HIV screening and rapid linkage to care. Our Sendero high-risk program was implemented this year, and over 200 high-risk patients were enrolled in that. Central Health Downtown Campus, we made significant abatement and leasing transactions in the past several years that have started to make significant changes we'll see in FY20 on the campus. As we mentioned earlier, specifically the Red River Realignment. And then finally, as Jeff mentioned earlier, the legislative success, which is causing a lot of great changes in how we can pay for and deliver care. So to close up the conversation about what's coming next with the budget, we've updated the budget calendar. This is not an easy task. But as you may know, the Travis Central Appraisal District, we may not get the final roll until August, which will impact the timeline. So we have made our first best effort to update the meeting schedule and some proposed dates, but I think it's important for this board to know that that is subject to change, and we would produce the required truth in taxation and public hearings as soon as we receive the information that allows us to do that. But what I wanted to just point out is that what we may end up doing is having to ask the board and the commissioners to approve our budget, and in a second series of meetings approve the tax rate. So the budget would need to be approved by October 1st. The tax rate may have to be approved after October 1st. So we appreciate you understanding that, having flexibility, and working with our team if we need to reschedule meetings. We know it's always a busy time, but we will do our best as soon as we get the information we need to get meetings scheduled so that we can accomplish the budget and the tax rate. So with that,
Thank you
We're
very
done.
much. Appreciate it, Lisa, Jeff, and John. There is no action on this item, but we are open for questions. And on that side, there.
Just a couple suggestions on the page that says capital plan, long-term. I might suggest calling that the capital improvement program,
Okay.
so that it's not confused with the capital reserves on the next page.
Okay.
You know, that word capital has different connotations, so that might provide more clarity. And then, on the next page, the FY 2020 capital reserves, you have facilities and operations. This is not the operating costs, is it?
no, I'm
Okay.
sorry. That is, I can update that to be a little more clear, but it's the cost of existing clinical operations or administrative, but it would be things like, the things that are in that line are building improvements, if we needed a new roof at one of the facilities that we own, or medical equipment. So it would be equipment to operate the clinical services or the administrative services.
Yeah, I think you might want to
Okay,
label that differently,
absolutely,
or
yeah.
break that out from
Yeah.
facilities and call it renewal and replacement, or whatever it
Okay.
actually is. And then when we do have actual projects, I know these are potential in the eastern Travis County, and we have some that we're commencing. I assume those will be broken out as projects with cash flow, and that you would show what the operating costs will be
Yes.
for those once they're
Yes.
completed? Okay,
Yes, once
great.
those are approved and the
Right.
project is going forward, but as you know, we have a lot of planning right
Oh, I
now.
do,
So we don't have
No, we
specific plan, projects approved.
No, we don't, but if we look at that next page, for instance, where we see FY 2019 accomplishments, primary care, you know, the mobile clinic, Austin's colony, so those would be the kinds of things that we would,
Yes, and most of those
See.
we hope to finish with the existing reserves, because those specific projects were on the previous capital plan. But yes, that's what it would look like.
okay. On the, skipping ahead about 2 pages, the FY 2019 accomplishment in medical management, the residential rooming, we have a strategic planning committee meeting coming up, and I would like to have more detail.
Yes, ma'am.
If we could, on that, and also on your transportation program, if we could have more detail on both of those at the upcoming strategic planning committee meeting, I think that would be
Happy
very
to.
helpful for
Happy
everyone.
to.
And then on the specialty care, FY 2020 specialty care initiatives, first of all, I want to commend you on all of these initiatives, the accomplishments in reducing waiting lists. I know there's more to do, but I want to commend you on what you've done so far, and these new initiatives. On the gastroenterology, we are working with the medical school on that,
Yes,
correct?
ma'am.
And are we working at all with, what is it, the big one, Austin Gastroenterology?
We today do not have a contract or any relationship with Austin Gastroenterology. Some of the,
But some of them are happening at the medical school, right?
I don't know about
Okay.
that. I do know that some of the Austin Gastroenterology providers work in the safety net system.
Right, okay,
I think at both Seton and at Community Care,
okay.
where those services take place.
Okay,
I think that relationship does exist, but we don't hold a separate relationship.
Okay, just curious about that. And then on the other accomplishments page, I just wanted to let everyone know that also at the strategic planning committee meeting, we will have a robust presentation on community outreach and engagement. Thank you.
Ms. Valades.
With respect to, thank you all, and thank you for your work that you're doing. I was wondering or curious, it says here that you're operating on a 7-year forecast at 6.3%. Did we make a decision on that, or
So
was it made after I left the meeting?
that is just the starting point for drafting the budget. The tax rate would be set by the board in the budget process. So that was just, this is one of the slides that we showed you at that meeting, and that was what we proceeded with preparing the draft budget, or we will proceed with preparing the draft budget.
Okay, I
Yeah,
thought it was,
we look for guidance to prepare the proposed budget. Again, it's not a final tax rate, but what we said was we would set it at either 6 or 6.3%, depending on the social equity finance item. And so our interpretation of it at this point is we would set it at 6.3%.
okay.
But again, it's not a, it's just a,
For 7 years.
well, that's what we're,
Assumptions.
that's what we're showing on the 5-year, or excuse me, on the 7-year forecast. It's just funding wise, year over year, what do our reserves and our days of cash on hand look like at that fixed rate over that period of time with the known things that we know now. Again, remember, there are things that we
Right.
don't know. But it's our best guess based on information that we had at the time we prepared it.
Okay. I thought I was here for that part of the conversation. I may have left, or I know I left early, so I didn't remember. I thought we were going to do at least a couple of them. I know at one point somebody suggested 6.5 or 8. I even went 8, you know.
But I think, Ms. Valdez, we did look at tables that outline that.
Okay, thank you.
And
I
so
left early, so I
we just decided that we would go with 6.3.
That's fine.
But at the time of we adopting the tax rate, if you feel that you want to put anything out there other than 6.3, that would be a matter for the board to consider.
Okay, thank you. With respect to the 2019 accomplishments primary care, as you're talking about the Eastern Travis County, I want to know why there's nothing there on, like, about the Kellum Road or anything that's located in Del Valley proper. You know, when we started down this road, I can remember fighting for Del Valley when the only thing we were talking about was Collins Park. Okay? And that was 3 years ago at least. And the people who live in Del Valley are not seeing much in Precinct 4 proper and the Del Valley area are not seeing much activity. And that was after Colony Park, that was our priority at the time. I believe we made a motion to that effect, and I don't see it. I understand the Eastern Crescent, but where is Del Valley?
So I think there are multiple initiatives. This
No,
was just
I know that.
highlighting a few of the more
Right.
recent ones.
But you see, that was at least 3 years ago when I fought for that. And maybe last year or a year and a half ago when we fought for the Del Valley. And we're talking about everything else. We're even talking about Pflugerville or other things, and we still don't have anything in Del Valley. And I have to speak out for that population.
Mr. Geeson?
Yes. So there's a couple things that are going on, and just to make sure we're talking about the right, or the same area of Travis County, Kellum Road, Elroy, southeast Travis County.
Yes, Southeast Travis County
That
specifically.
larger area.
Yes.
So we have started looking at other pieces of property, and this is pursuant to a conversation that we had regarding the Kellum Road site. But we're also continuing discussions with UT School of Nursing. I know that with Holly and Larry and I met this week, and I think there's another round of discussions to be had on that as well. Third, community care is in the Travis County Employees Clinic 2 days out of the week plus some Saturday hours. I'm sorry,
Yeah,
4.
3. I believe it's
3 days.
3
See,
days.
3 fingers going up in here,
Three.
number 4. So
For me.
It's 3, I
Well, we
believe.
originally were gonna get like 2 or
Yeah,
2 and a half, and then we went
we'll
4.
stick with, all right.
It's 3.
But then again, that's still on the other
3
side.
days, thank you. And so you do have some services out there, and then there are other clinics that are also seeing people that live in that area out there. Is it at a clinic that's close by to where they live? Preferably, we would like to have it that way, and
What
that's what
clinic
we're
is that?
looking for. They're seen at other clinics. They-
No, but what is in their neighborhood where they live?
Right now, the closest thing would be the Travis County Employees Clinic that we have part-time services. And then the fourth thing that I'll put out that also positively affects that area is the mobile clinic that we have at Creedmoor, which also serves that, people in that general vicinity, not just the town of Creedmoor proper.
And how long is that going to be there? I thought, I would understood that the mobile clinic was going to be mobile and going around, is it a schedule that the public will know is going to be made available to them?
Yes, we've already been advertising this both in the media as well as locally. There within Creedmoor, yes ma'am.
Okay. I'd love to see that. Press
We-
release that shares that information.
We'll be happy to resend it.
I appreciate it, thank you so much. But again, not to beat a dead horse, too much, just a little. You know, I'm struggling to understand, maybe we have to have this discussion in executive session to see what the problem is with respect to the Kellum Road location.
And
Because if
Were
this is
you-
gonna continue to be another year or two that we're gonna have to wait, then I suggest we change partners. And
Okay.
go back to trying to get community care in.
Ms. Valdez, Mr. Geisler?
And forgive me for asking, but just to refresh my memory, whenever we covered this, I think meeting before last, and what our strategy would be for that region, were you present for that discussion?
I left early, I don't know if I left
Okay.
twice, I know I left at the last budget meeting,
Okay.
I left early. And I know that y'all went into executive session, but
I don't know if we're properly posted.
No, we're not.
What I was gonna say is if the next person wants to talk about this particular item, it's really not about the fiscal year 2020 budget. If you can frame it in, we have money in the budget for these types of initiatives, that would be fun.
Oh, great, so, with respect to, I guess rephrasing it, as it is included in our budget, preparation for upcoming budget discussion, and we did highlight every other initiative in the Eastern Crescent, I'd like to make sure that we, in our upcoming budget, if we have money left over in this one or in the other one, that we prioritize the Del Valley proper location for that community that we made promises to, okay? And so that's just my comment. And then, again, I have another question about, I think it was just one more.
Ms. Valdez,
Oh, with
you
respect
got
to-
it? Because while you're finding your question, I have another member that wants to ask a question.
Go ahead.
Go ahead.
My question is really to your comments to her question.
Okay.
On Del Valle, I agree with you in terms of Del Valle. We need to fix something here with that soon because we have made, but I think we also need to define what we mean by Del Valley because we talk about it generically.
Precinct 4.
Okay, precinct 4 because
Yes,
part
I
of.
said that.
Oh,
I said
okay,
precinct.
okay, but when we're talking about planning, you're saying we just need to make sure because we are doing something in Hornsby Bend, which is part of Del Valley Independent School
Right, but
District.
that's precinct 1.
I know, but we're saying Del Valley, so I just say we just need to make sure that we be clear when we
Yes.
say Del Valley.
I did say precinct 4. I said
Yeah,
Del Valley and I said precinct 4
Yeah, afterwards, but
specifically.
afterwards.
But I appreciate that,
I
Shannon.
think it would be helpful if we just refer to it as precinct 1 as opposed to Del Valley. That makes it a lot
Precinct
easier.
4.
Yeah.
Oliver?
So if my recollection is correct, a couple of years ago when we were talking about the budget and we had leftover IGT, I think it was about $8 million. That's where this $8 million reserved for trying to help build something in Del Valley came from, as we were building it into the following year's budget. This year, when I'm looking at it, it looks like there's 50 million of unused IGT. And it looks like from the comments earlier in the previous LPPF discussion, the provider tax would cover the September IGT and the November IGT. So we have budgeted $50 million of unused IGT, and this is what I advocated for 2 years ago. Let's take that 50 million of budgeted but unallocated IGT. It's a lot of money that can do a lot of good. And I think that's what we need to decide. There's gonna be it appears right now, and Jeff, you can correct me if we're gonna
Yeah.
do something that will eat into that $50 million of
Yeah,
unused IGT.
Before we go and state that, I mean, hopefully next week, we can bring you estimates on what our FY19 estimates look like, because I think you'll see, yes, there may be some IGT that the LPPS are providing, but there will be some other costs that we'll be paying for that we didn't anticipate paying for. So if you'll just let us bring the estimate, I think you'll have a little better idea of where we end up related to that.
Then I will defer till next week.
Thank you. Appreciate it. Ms. Valdez, you had one last question. Did you find it?
Well, it's kind of, I guess, I was listening to KUT with respect to the opioid epidemic, and there was maybe it's something I should have an offline conversation about, but just I wanted to know whether or not we're keeping track of the numbers of pills that are being dispensed by the doctors here in Travis County, to know where they might be coming from.
Question.
And I don't know if there's a budget allocation that's needed to be able to do that, but I know I would be very interested in knowing what the pills,
Happy
number
to
of
follow up
pills.
with you on that.
Yeah, I thank you very much, because it was,
Thank you, Ms. Valdez. Ms. Greenberg?
Yes, just to Mr. Cano's point, I understand, and you'll provide more detail on this next week, that we are going to have some costs upcoming that we have not had previously, is that correct?
Yes.
And you'll provide more information on that?
Yeah, so
Okay.
just to be clear, related around IGT, typically uncompensated care, which again is our largest budgetary use, there usually are semi-annual transfers, and we've done one semi-annual transfer called the advance piece of it. So I think, Ms. Oliver, what you're referring to is kind of what's called the final IGT, and we'll bring some information related around a little bit fuller picture of our budget.
And if
for
you'll just
19.
clarify, because it did say that the provider tax would cover all of the September IGT and the November, the local portion?
It's the final uncompensated care for demonstration year 8, which will occur in September. And then in November, it's the Europe program, which we currently don't participate in. So
Right.
it's something that the LPPF will provide funding for, but Central Health doesn't participate in that program. We don't have the capacity to provide the local funds for that.
But I think my question on that is, if the provider tax, according to this page here, says it would generate approximately 35 million in local funds to be used for intergovernmental transfers, and the amount would be sufficient to generate the local portion for the September UC payment and the November 2019 Europe payment. So if that's the case, we still have budgeted $50 million that we've not used in this year's budget. And that's what I'm saying, if you could just clarify that next
That's not true,
week.
but I'll bring the information. I just want to make sure that you understand that we haven't participated in Europe ever.
Ever.
Right, no, I know that, but I'm just saying that that's
And
what this
for uncompensated
says.
care, we've made 1 of 2 IGT transfers. So typically, our budget for an annual participation in the uncompensated care is about 50 million, but we've already provided the advance piece, so 1 of the 2 IGTs.
Well, I skipped ahead in the presentation to look at the financials for this year and this month, and that's what I'm saying.
And when we get to that item, I actually think I can give you a little more information on that.
Okay,
So,
Great, thank you.
great.
Okay, thank you. Dr. Zamora?
Dr. Chair, correct me if I'm wrong, I was going to answer Manager Valdez's question about opioids and specific numbers per provider. It's going to be HIPAA information. I doubt you're going to get that specific. Each provider has access to what's called a prescription monitoring program through the Board of Pharmacy. Each provider has capacity to look at patients and where they're going to. More than that, I don't think you're going to get an exact number.
thank you for that information, but there was an investigative report that was done. It was talked about on KUT. They even said you could go to their website and they'll access they broke the numbers game, and they are actually able to go. You can go to the state, to the county, to the city, and they will tell you what are the pharmacies, how many pills are coming out of those pharmacies. They'll even tell you the doctors that are prescribing. So in one town, they used an example in Pennsylvania somewhere where there's like 3,000 people. They had over 3 million pills in that 1 year distributed. It was a huge amount. It was crazy. But it was an NPR report that said if you want to know that information, you just access it through them.
Okay, well, John will follow up with you on that,
It's
and
pretty easy.
appreciate the information, Dr. Zamora.
Thank you.
Any other questions? Okay, thank you very much, appreciate it. Item number 5, discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated, including the effect of federal legislative and regulatory actions. Presenting is Wes Sterkowski of Sendero. We will have an open session initially, and then I will call for a closed session. And the first part of that closed session will deal with a consultation with attorney to give the board some explanation. And then we will continue on with information regarding Sendero in the closed session. So, Wes, the floor is yours.
Okay. Thank you. I did write a few things down because I'm thinking slowly because of allergies. But since our last meeting, a great deal of work has come together. And so I will highlight just a few of those things we're going to focus on this evening. If we can go to the first slide. I guess there's already some slides in your packet too. Oh, I guess some of the colors show up, but that's fine. So the first item is the Wakely 2019 preliminary risk adjusted estimate. We are very pleased that the risk adjustment is working as expected. So normally, the risk adjustment would require us to set aside premiums from current members, which we would end up paying back to the statewide pool. However, this year, we are successfully redirecting those funds back to improve access to care for the MAP members and care delivery for them. Second point, the actuarial reviews we've had done by both Wakely Consulting and Novarest. These have both been completed. Sendero's internal actuaries, Wakely Consulting, they have a great deal of marketplace experience, including more risk adjustment experience than is available anywhere else. From them, in addition to our normal work with them, we got them to write a little memo for ourselves. Additionally, we contracted once again with Novarest for an independent review for Central Health. We'll be reviewing that tonight, similar to last year. For the new members on the board, Novarest is an actuarial firm that performed the independent review for Central Health last year. Our work is performed directly by Donna Novak, who has close to 4 decades direct experience working with insurers, states, NAIC, HHS, CMS. So we are very grateful that she agreed to work on this. It was a lot of hours, definitely on their part, and hard work, to which we are grateful for her. Both actuaries took independent approaches to analyzing probably 3 issues and corresponding projections that we'll be discussing tonight. Basically, it's Sendero 2019, Sendero in the CHAP program, and Sendero 2020 forward. For tonight, I need to thank the board and Central Health for the opportunity to discuss these projections in greater detail in closed session and in support of the CHAP program, whereby, Sendero, in addition to improving access to care for the community at large, is directly improving access to care for the MAP members.
Okay.
So with that,
Thank you very much. Before we go into closed sessions, any questions based on the preliminary information that Wes has provided? If not, I would announce that the board is convening in closed session to discuss agenda item 5 under section 551.085 and 55 of the Texas Government Code, Governing Board of Certain Providers of Healthcare Services, and section 551.071 of the Texas Government Code, Consultation with Attorney.
like what I like, so sometimes I have to get it anyway.
Okay.
I know.
The committee is reconvening in open session. There will be no action taken on item number 5. Agenda item number 6, receive and discuss an update from Community Care regarding healthcare delivery strategies and healthcare delivery sites. Presenting will be Jason Fournier of Community Care.
Thank you so
Jason.
much, Dr. Bell, and good evening, Board of Managers. Privileged to be here as usual. Really appreciate your time this evening. I think my presentation is going to be fairly brief, and welcome, Julie, you're not a new member, but this is the first time I've interacted with you and others on the board. Over the last year or two, many of you are aware of the fact that we've been working with our Central Health partners as well as our Community Care Board of Directors on health center realignment as it relates to a lot of our sites and various different initiatives that we've going on, expanding our footprint. This calendar year, we're expecting to serve over 100,000 unique individuals. We're actually seeing more folks who are sliding fee scale or MAP basic, MAP than ever before. The next slide just goes ahead and really, and you have this in your packet, just kind of outlines some of the work over the last 12 months or so, starting at the beginning of this year, and then moving forward into next year, into March or so. And we've got a 3, 4, 5 year plan that we've shared with you. When we get out into future years, it becomes a little bit more difficult to project the actual timing. What you see here on this slide in green are things that have actually already been accomplished. So earlier this year, you may recall that with support from Seton and the use of their space in the old Kosmetsky Clinic, we opened up our Care Connections Clinic, and that was a consolidation of both Healthcare for the Homeless initiative that we have and a complex primary care. And so as we proceed throughout the year to date for 2019, we've added 6 different initiatives that have occurred. And really increasing our footprint both within the Eastern Crescent, but within Austin proper itself in Travis County. That Care Connections Clinic is a great one because this is really about patients. And we had absorbed a couple of years ago in 2017, Seton's Total Health program. And I was just talking with the principal physicians that are at that site earlier this week, and they'd indicated since we've been involved with this particular clinic, there's 14 amputations that have been averted as a result of the direct care that's being provided there. And that's just a small piece of a lot of the work that's going on. Some of the other things that have happened year to date, just by way of a reminder, is in early March, we established a home visit initiative in Austin's Colony, Hornsby Bend, increasing capacity, with the eye to the fact that later this year, there's a modular that's going to be happening within and at the ESD in that location, ESD4. And then we converted some space with the support of the federal government in the Southeast Health and Wellness Center and with Central Health support to actually start providing convenient care walk-in clinic at that site. That happened in March. At the same time, we converted our William Cannon site in Dove Springs from walk-in to actually primary care to increase the primary care services more comprehensively in Dove Springs. And then we consolidated because, as you know, the medical office building on the campus around Brackenridge is being repurposed and coming down. We relocated the Blackstock Family Medicine residency program into Southeast Health and Wellness. And all of those are doing quite well. And the most recent addition that John Morgan indicated earlier is with our partners here at Central Health. We've initiated a mobile health clinic that's going 3 days currently out to Colony Park and 2 days out to Creedmoor, and really have increased the footprint in those areas and the services there. So really want to talk about what the future holds for us, and really tonight really apprise the board. Through Mike last week had sent a letter to you apprising you of a very exciting initiative that we've been negotiating and working on for a little bit of time, and that's really the acquisition and absorption of Carousel Pediatrics into community care. And we expect that to happen later this year, probably towards the end of September. There's a couple of things that we still need to do relative to that initiative. One of them is seeking approval to add the sites into our federal scope of project as a federally qualified health center. And so that's just a formal process. Anytime, for those that are maybe less familiar, we add a site, delete a site, change a site, we have to ask the federal government for their permission to do that. That's just part of being a community health center. By way of background, Carousel Pediatrics was established in 2002 and was really established through the principal physician owner, Dr. Glenn Wood, and who really early on recognized that there was a deficit of services for children, adolescents in Austin, Travis County, specifically on the Medicaid front. And over the years, that practice has grown fairly significantly. And so as we talked with them about alignment and what their needs and what our needs were, there was natural synergy around there. They currently operate 5 locations, 4 larger locations here in Travis County, all within Austin. You can see off on the right-hand side of the booklet where their locations are: North Lamar, Springdale, Southbrook, which is really Dove Springs, and then Riverside, and then a very small footprint up in Round Rock, which is their most recent site. It's been open for less than 2 years. On the medical, and each one of their locations is located near or in very close proximity to lower income, lower resource communities. 27 medical providers, currently 3 dentists within their facility, so comprehensive medical, dental practice. Additional to that is therapy services that they offer: speech, physical therapy, and occupational therapy being offered to the kids within their sites. And so when we talked with them, recognizing that they're a highly regarded, very robust clinical provider of care, and their quality outcomes are very good, we recognized that there was a way for us to support the services that are occurring within those sites in a long term. Of significant importance is the principal is retiring. And so that's part of the conversations that we've had. And so with the transition, with the practice size, it made sense for them to be looking then potentially at how they transition the practice. And so that's one of the reasons why the conversation started with us. Absorption of Carousel into community care makes sense for many different reasons, one of which is really alignment with our mission, right? It's really about going ahead and strengthening the health and well-being of the communities we serve. In this case, they're concentrating on a pediatric community. I think out of the 100,000 folks that community care is going to serve this year, the vast majority are adults. And 66% of our adult patients, so think almost 56,000 unique individuals, are uninsured, the vast majority of which are Travis County residents. Of the pediatric patients community care serves right now, it's roughly based on calendar year 2018, we served a little bit over 22,500 unique children, of which 23.5% were uninsured. So we're seeing a lot of uninsured kids within our community that are already coming through our door. But a little more than 20% of our overall patient population is pediatrics. In our site visit with the Health Resources and Service Administration in 2017, in September of 2017, one of the things they shared with us as administrators and staff at Community Care and our board of directors was that the Health Resources and Service Administration, which is responsible for providing the grants for federally qualified health centers, encouraged us to look at ways to diversify our patient population. And that was one of the things that our board of directors charged us with. This absorption of Carousel in will allow us to get closer to what other community health centers in the state of Texas and across the country look like in terms of more balance in terms of patient population from both a family, generational perspective, but it won't get us fully there. The average community health center, unless you get close to the border here in Texas, averages about 60 to 65 to 70% in terms of a patient population that is Medicaid or Medicare, depending on rurality versus urban areas where services are being provided, and significantly less uninsured population comparative to what we serve currently. So from a financial stewardship perspective, there's a lot of reasons for us to be doing this. Through the absorption as well, we would see longitudinally then a decrease in our cost per encounter. As a result, we would see a decrease just simply because this is a lower acuity, lower intense population. So the cost of providing services across our network of health centers would be reduced as a result as well. So there's value there as well. And our board has reviewed this, of course, and thinks that this is a very much an effective use of our resources. Our goal and one of our strategic priorities is take our existing infrastructure and leverage that into more direct clinical care services, for which we're committed to do and have been doing. So with that stated, there's other initiatives that are going to come online. Going back to that initial slide, we expect later this year as it relates to working with Austin Intermediate School District and a school-based health center, hopefully in October, over at the Aikens High School. That's one of the initiatives that we have, in addition to Carousel coming on line later this year. We're working with our partners here at Central Health on the Austin Colony, Hornsby Bend Modular. And then early next year, probably by April, we've been working with HACA about establishing a small medical dental practice within the Chalmers development. And of course, this graphic goes on beyond just next March, April, but keeping it to 10 initiatives for right now, current year, and then the next little bit less than 9 months that way. So happy to answer any questions you have at this point in time.
Thank you so much, Jason. We appreciate it. Manager Greenberg, please.
Yes, first, I want to thank you and your staff and everyone who has been involved in the carousel absorption, as you called it. I think this is just a terrific opportunity for us, for the community, for children, and as you pointed out, diversifying. So thank you so much for that. You mentioned healthcare being provided to the homeless. And of course, this is a very big topic nationwide and in Austin right now. Just last night, I was at the forum that the Downtown Austin Alliance had. Would it be possible for you to work with Monica, who's sitting right here, and provide more details on, and I'd like kind of a robust memo of all the different services and that we are providing within our enterprise to help to those who are homeless. Given that we're serving 200% and below of FPL, we know that there's a substantial homeless population, maybe about 2 or 3 years worth of data on that, and also the types of services. That would be, I think, very helpful information to have. Also, I am delighted to hear about the partnership with HACA at Chalmers, and would it would be great if we could see more details on that as they're available. And I would be delighted to see further partnerships with HACA in the future, that the Housing Authority of the City of Austin, given their residents and the needs of their residents. That would be helpful. Also, and I will visit more with Monica offline, and she can get with you. It was brought to my attention that there is some type of housing that has seniors in it that the City of Austin has. It's probably in the Rumberg neighborhood where residents may need more attention. Let's visit offline, and we can, it's in a particular council member's district, and we can perhaps look at if there's anything that's being provided there, and if not, what could be in the future. Thank you.
Thank you, Ms. Greenberg. Mr. Jones?
Just a couple of quick questions. First one is, you mentioned that, I guess historically, we have not been seen as many children or kids compared to adults and perhaps the other ones. Is there any reason that has been the case?
You know,
prior to carousel and so on.
Yeah, well, no, just generally as it relates to community care, and then our, you know, our predecessor in the City of Austin clinics as well. I think part of it's just how the clinics grew up, starting in the early 1970s. Historically, I think the target population is what we see now as the medical access program, the MAP program population. And so as the health centers evolved over time, the highest need that was identified has been and continues to be uninsured adults. And I think unlike uninsured adults, there have been other within the private sector have stepped forward to address the needs a little bit more comprehensively on the pediatric side because there was a payer that was available to do that on the Medicaid side. Some of those practices have struggled over time, When we take a look at pediatric dentistry, for example, there are quite a few providers out there that are providing pediatric dental services, but there's still a need there as well. But I think it's just an evolution in terms of historically and a continuance of us targeting the highest need population who have no one serving them and looking at gaps in those services and filling those gaps in, sir.
But generationally, those who grew up in the 70s, 80s, and 90s are now the adults.
Correct.
And so they didn't get services then, but they're able to, or have been able to evolve over time through our system. I'm just wondering why we didn't put a greater effort, not you, but the system in terms of addressing that younger population earlier.
Yeah, I don't, Manager Jones, I'm not 100% sure why. It is atypical for a health center or community health center not to look at all life cycles and serve all life cycles.
And then the last question was,
Yes.
a piggyback of my colleague, Manager Greenberg, about Chalmers. Why Chalmers? I think I know the answer, but I'd like for you to sort of you had opportunity with HACA. Did HACA identify other locations, or Chalmers was just convenient, it's targeted, it's unique? I mean, why Chalmers?
So I think a couple different things. As we had conversations with HACA about what possibilities were with their redevelopment of Chalmers and it becoming the largest, soon to be their largest housing development, it made sense for us to be looking at what, if any, services should be provided on site. I think as we look at health center realignment, we have a very large asset right now that's across the street in East Austin Health Center, and that was our original and is the original health center as established here in Austin back in the 70s. That's targeting pediatrics and OBGYN services, and a lot of those community members no longer live in that area, so we see that asset potentially as being repurposed into the future as we look at becoming more proximal to the residents. And when we take a look at the impact of gentrification in East Austin, one of the populations with our partners at HACA that we think is going to continue to need our services is the publicly housed population. And so partnering with them made a lot of sense as it relates to their community health workers, our expertise on the medical side. The other is we've never had dental services in East Austin. And so this provided us the opportunity to establish dental footprint within their space. We have worked as it relates to Rosewood Courts on some of the other sites, and we're hopeful that this is the first step of a partnership that continues to evolve with them. Speaking to Manager Greenberg's comment, each one of those we're going to follow up with you on, but relative to seniors, we are working with the City of Austin, actually submitted a proposal to actually increase services and home visits within the lakeside property. So I'm not familiar with the need in Runberg. We'll certainly take a look at that, but part of our model is looking at how do we get to folks where they live, including home visits for our aging population who are going to continue to reside either in publicly housed or in voucher related housing initiatives, and or folks who are lower resource who happen to be living and continue to live within the heart of the city. How do we make sure that they have access not only to a care provider, but also to the pharmaceutics they need as well, and how we best support that, Shannon. So.
Okay, so you're looking at Lakeside, did I say?
Yeah, that's what we put into an application. There was a small grant process through the City of Austin that we responded
That's a
to.
good location, that's what I was.
Yeah, that for a pilot, but we would see that as expanding potentially outwards as well. So,
Thank you.
Thank you, Mr. Jones. Anyone else? Thank you so much, Jason.
thank you,
Appreciate
Dr.
it.
Appreciate your time this evening, everyone.
Thank you. Okay, agenda item number 7, receive and discuss a report of the June 2019 financial statements for the Community Care Collaborative. Presenting is Lisa Owens. Welcome, Lisa, again.
Hello. Okay. Well, we are 75% of the way through the year, 3/4 of the way through the year. So we have our June financial statements. Just a few highlights that are really just previews into July. We do have in July and in the summer another IGT coming for the district program. So revenue for the CCC as well as the summer payment to UT Medical School as part of the affiliation agreement. Our cash as of June is at $35 million. Our total liabilities at $15 million, and net assets at the end of June are $19 million. So those highlights kind of hit some of the numbers on our balance sheet. Again, cash and cash equivalents at 6/30 are 34 million. Total assets are predominantly cash and cash equivalents. The variance, as I've pointed out over the past several months, is the timing on that DSRIP revenue, which, as I mentioned, you'll see in July. And accounts payable and accrued liabilities is 14.8 million. That is down significantly to last year due to intercompany payables between Central Health and the CCC, as well as provider payables are less this year as we are making much faster claim submissions are being paid much faster. We're very excited about the process improvement. Our total liabilities are at 16.3 million and net assets at 18.5. So again, total liabilities and net assets at 34.8 million. So looking at the year-to-date sources and uses of funds, as of June 30th, DSRIP revenue was at 32 million. We did receive over $40 million in DSRIP revenue in July, so you'll see the additional funds coming into the CCC. And as of June 30th, $83 million sources of funds. Our uses of funds, I'll go into more detail on the healthcare delivery in the next few slides. We do estimate that providers working in the DSRIP program on the DSRIP outcomes, we have $8.1 million in expenditures there, so total uses as of June 30th at about 50% of our budget at just over 69 million. Sources over uses year to date at 13.5 million. So healthcare delivery, again, as I mentioned, $61.5 million year to date. That's about 65% of our budget. We have more detail on primary and specialty care. I've mentioned in the past on specialty behavioral health, we will be a little bit over budget as we are funding the AISD behavioral health program through the CCC. Our post-acute care, we did amend the budget, you'll recall, and amend the contracts that support that post-acute care that we've discussed in several meetings. So we do anticipate being close to over $2 million in expenditures there. Pharmacy, John mentioned this in the accomplishments and budget presentation, but the MAP Basic program is offering additional pharmacy benefits to our patients, which were formerly sliding fee scale patients. And then our healthcare delivery operations, we have a little more information at the end of the presentation, but we are just at 53% of the budget, which was amended to shift more administrative costs to post-acute care. So again, year to date, we are at about 65% of the budget. Now specifically in primary care, we're at 68%. And I would just point out, I think we've discussed this many times, but we are shifting more of the primary care contracts to performance-based incentives that would happen later in the year. So you'll see a timing shift where we do have pretty routine expenditures on a monthly basis with our partners, but you'll see some of those outcome-based payments in the last month of the year in September. On specialty care, no specific changes or highlights from previous months that I would pull out of this, but what I would say is John mentioned a general surgery earlier, which was an exciting new initiative, and that you will start to see expenses in, we hope, in the near future. And I would continue to highlight that we worked very hard in the budget for FY19 to carve out budgets by types of specialty. So for example, with our partners, where they provide multiple types and levels of care in different specialties, such as community care, we may be a little bit over. You'll see we're already over budget in pulmonology, but we're not over our contracted amounts with our partners. Those would be where we had larger specialty care line items. We estimated the amount that would be paid out in pulmonology versus rheumatology, and they'll be a little over budget in some cases and under budget in other cases. So total specialty care is at 44% of our budget. We are at $4.8 million year to date. And then finally, on the operations side, these are the departments that many of, providing much of the care and services that John talked about in our CCC operations and healthcare delivery. 53% overall of budget as we look at most of those being well under 70% as we are at 75% of the year. And I will answer any questions.
Thank you very much, Lisa. Manager Greenberg and then Manager Oliver.
So in the context of the budget, up to date, MAP Basic has been 6 months eligibility, right? And so has MAP, they've both been 6 months eligibility, is that correct?
Matt Basic is actually a 12-month
In the
enrollment.
current budget, in what we're looking at here?
Yes, Matt Basic is a 12-month
Is it
enrollment.
12 months? Okay,
Yes, ma'am.
but MAP is only at 6 months?
That's correct.
Is there any anticipated change to that?
That is something that we're definitely looking at, something that we're potentially looking at even for next year. As you
Okay.
remember, the board approved previously expansions to the MAP enrollment program
Yes.
for 2 or more chronic condition patients and
Right.
also raising the FPL floor. So we're always looking at those different program parameters
Well-
based on available funding.
I guess, given that the current budget is 12 months for MAP Basic, but not for MAP?
Yes, ma'am.
Can we have discussions going forward about 12 months for MAP?
Yes, ma'am,
Thank you.
absolutely.
Thank you, Ms. Greenberg. Ms. Oliver.
So I think I heard you say there's an additional 40 million in district coming in?
Yes.
So that would mean we'll be over budget.
Yes.
That's a good.
Yep, but
that's
I would
nice.
say, and I'm gonna look at Jeff, there were some DY8 incentives that were paid, so that is a timing difference.
Yeah, yeah, that happens.
Yeah.
But that's so good. That's really good.
Thank you very much. Appreciate you both, John and Lisa. Lisa, you can stay up there because agenda item 8, receive and discuss a report on the June 2019 financial statements for Central Health.
Okay, so highlights, we continue to collect small amounts of tax revenue, but we have collected a significant portion of our tax revenue as of June 2018. And the IGT as of June is 90 million. However, we did IGT $26 million on July 2nd. So there were additional IGTs that have happened for the programs that are in the budget.
Gotcha.
So a quick look at the balance sheet. No significant transactions this month to report. I will share that our cash position, short-term investments or total current assets is a little bit higher. Again, we collected an additional $15 to $16 million in tax revenue this year, and also the timing of that IGT did shift from June to July. So if you look at last year, there is a timing difference there. Non-current assets, no changes since last month. And then on capital assets, we've had about $2.3 million in new capital investments this year, and then depreciation. So total capital assets at $114 million year to date, or as of June 30th. Total assets at $376 million. On our liabilities and net assets, current liabilities are just $6.6 million. We have significantly less liabilities year over year. As well, our debt service or non-current liabilities is at $8.5 million. So total liabilities for the organization is just $15 million. That leaves our total net assets at $361 million, total liabilities and net assets at $376 million. On our sources of uses, we did have about $300,000 in property tax revenue come in. We had our lease revenue from Seton as well as UT, ground lease come in, and then other revenue continues to be really strong performance on our investments. So that is investment income in the other revenue. $1.4 million in sources of funds in June. Year-to-date, we're at $263.8 million. So with at 102% of budget, which is very exciting. Our healthcare delivery was $13 million in expenses this month, year-to-date at $152 million. I'll talk more about that in the next couple slides. Our administrative program, about $500,000 a month, and year-to-date, we are at just 51% of our budget. And then tax collection expenses kind of matches up with the tax that came in. So that is a smaller amount monthly, but we are at just about 91% of the budget year-to-date. So total uses are at $14.4 million. Excess sources over uses is negative $13 million, but year-to-date, $105 million. So looking in more detail at our healthcare delivery, as I mentioned, the IGT, we have $90 million in IGT year-to-date. We did make a disproportionate share that's made in advance payments, and then a final payment was made for the year in the disproportionate share program of $12.3 million this month. And then, as I mentioned, you'll see another $26 million in July. Provider care, primary care contracts, and medical administration was at approximately $172,000 this year. Year-to-date at $25.2 million. And then service expansion funds, we have a lot of great work happening in our sexual and reproductive health programs. So as we talk about the budget and going into next year, that will become more of an ongoing programmatic. In the current year's budget, we had that as a kind of a new initiative, a service expansion fund. So currently, we're at about 40% of the $1 million budget at $412,000. On the next slide, we have a little bit more information on our healthcare delivery operating costs, which we're at about $531,000 this month. Year-to-date at $4.8 million, again at just about 50% of our budget. And then other costs being expenses in the campus redevelopment and our ACA enrollment and Sendero high-risk program premiums. Total other costs at $791,000 for the month. And then total healthcare delivery again at $13.9 million. Year-to-date at $152 million. And with that, I can answer any questions.
Thank you very much, Lisa. Ms. Oliver?
Okay, forgive me, I always forget what our fiscal year end, is it September or?
September 30th.
So a lot of these look like they're not tracking, and I know not all of them, some of it is timing issue. One of them is our lease revenue, we're about 50% on our budget. And that could be when we were doing our budget, the timing of when we thought some of these ground leases would go in. So if you could speak to that and maybe some of the expenses, because we're gonna, I mean, it looks like we're gonna do, well, I mean, if some of these expenses don't go through.
Right.
And they might get pushed into next year. And
Right.
Yeah.
So on the lease revenue, there were a lot of lease revenue estimates made in the budget process that we just didn't know. The one thing I would say is we did receive some lease revenue for year 2 and year 3 that is deferred revenue. So that's not, that is a source of funds, and that cash came in, and you'll see that on the balance sheet. However, those were estimates that have not necessarily been triggered. I think there's also the CEC utilities and some other things.
Yeah, there was a chiller project that was approved, and we had hoped that it would be completed by December of 2018, and then there was a 9-month lease repayment. It didn't get completed until just recently, so it'll bleed over into next year.
Yeah.
Okay. And
then on the expenses, I think you're right, it is timing sometimes, and then it's also just unknowns. We are planning for projects that may not start until later in the year, and unknowns. But we will be bringing forward as part of the budget, which I think will help get a better picture, what we use as a current year estimate. So part of the budgeting process is looking at contingency reserves So we use the current year-end estimate to really try to look at what's going to be an available resource that rolls over into next year.
Well,
So
what's
you'll
the
see
debt
more detail.
service? Is that, did we anticipate taking on debt that we didn't take on? Because that's really low too,
I'm
compared.
sorry.
The COs at the Southeast Health Alliance.
So we have, I'm sorry.
No, I mean, like, we're only 19% of our budget.
8.7.
Oh, yeah, sorry. So it's an expense, but it's really low compared to what the budget is.
Let me look into that, actually. That, we made a million, I think we need to capture the $1 million principal payment. So let me look into that. We might not be pulling the right number there.
Thank
That's
you.
great.
Thank you, thank you.
Thank you, Ms. Oliver. Anything else? Ms. Greenberg?
Yeah, I was wondering about that, 'cause we have, the only debt I know that we have are COs
Yes.
on Southeast Health and Wellness, but that
Yes.
does look.
Yes,
Low.
and we anticipate being
So
very
maybe
close to
only
budget there.
cover
And
interest
so
and not
we,
principal?
yes, it looks like we need to just
We
pick up
only
the
make
principal.
one debt service payment a year, I believe, so. We'll look into that.
Oh, it's
but
not
it's-
semi-annual, it's just annual?
I believe it's in there.
Oh, okay. Well, that might be.
Another, I guess, question or observation I had, expenses being low can be a double-edged sword,
Mhm.
right? So on the one hand, if expenses are lower because we were projecting that certain new initiatives would come online and they've been delayed, that's one thing, or that we are being more efficient. But if expenses are lower because we are not spending as much on service delivery as we've hoped, then that may not be a good thing. I just wanted to
Mhm.
put that out there and maybe we can dig a little to see.
Mr. Canola?
Yeah, so, and I think you'll see this next week, but,
Okay.
so we've talked about expenses being low, but there are gonna be expenses that are gonna be high.
Okay,
And so one of those that you'll see that's higher than the budget would be the CCC member payment.
yes, I understand.
So just as a, you know, we'll
Yes.
get our best estimate together next week to
Right.
present, but I just didn't want there to be any generalizations that if expenses look low, that's just gonna trend that way for the rest
No,
of the year.
no, I understand, as I said earlier, that next week we may see some new expenses that we haven't seen previously, right, that would eat into that.
So thank you for your patience on
Sure.
that. We'll try to
Solid.
get it to you.
So we currently have like $105 million surplus as of now, like 75% into our year. 26 million is going to IGT. Some portion of that will go to our CCC payment. But it still looks like we're perhaps on track to have a sizable
Yeah,
surplus.
I think we will, but remember, we have, you know, we're trying to build reserves. If you
Yeah,
go back
right,
and look
right,
at
right.
the 7-year forecast, we're trying to build our reserves up for when
Yeah.
Deseret finally goes away. I mean, we'll have to, as a enterprise, we'll have to absorb that
Okay.
loss of federal funding, so thank you for bearing with me.
Yeah,
It
no
worries.
seems kind
Yeah.
of simple, but
Yeah.
there's just a little more latitude related to looking at the bigger
Yeah,
picture.
totally fine, totally fine.
Lots of moving parts.
Yeah.
Yes.
Right. Is that it for the board questions? All right, Lisa, you're in it for the long haul because you have agenda item number 9. Discuss and take appropriate action on agreements for external auditing services for Central Health and Community Care Collaborative. And I'd like to say before Lisa starts that for this item, staff will outline the process that was done to evaluate the proposals for hiring an external auditing firm and how the results led them to recommend the top candidate to us to approve. Because this procurement is still in process and only ends after we approve the top candidate, there are certain specific details that the staff are unable to share during this presentation. However, the presentation is structured to give you, as board member, as much information as legally possible to understand the process that was implemented and inform your vote of either approval, disapproval, or abstention. Lisa.
Okay, so I would like to reiterate, this is still an open procurement. However, Central Health issued a request for proposals, or an RFP, for Audit and Tax Services on May 30th. We issued the RFP on behalf of our enterprise partners, Central Health, Community Care, and the CCC. We advertised in multiple publications and distributed the RFP via BidSync. Over 4,000 firms were notified via BidSync and other means. Over 9% were minority business owned, approximately 8% were women business owned, and approximately 15% of that were small businesses. Proposals were due on June 24th, and we had 6 responsive proposals. Our evaluation team consisted of 5 experts in our staff, representing the 3 different entities, and also representing different departments and different lengths of tenure within the organization. The evaluation team reviewed proposals for qualifications first and created a short list. That short list had a logical break, and 2 vendors were selected on the short list. And then the vendors evaluated and determined that Maxwell Lock and Ritter was the best value to the enterprise partners. So we would recommend that the Board of Managers engage Maxwell Lock and Ritter as our financial audit firm in a contract in the amount with Central Health not to exceed $35,000, and with the Community Care Collaborative not to exceed $30,000.
Thank you very much, Lisa. I'd like to get a motion on the table before I open for discussion.
I move that the committee endorse the selection of Maxwell Lock and Ritter in connection with RFP number 1901-004 for Auditing and Tax Services, and further move that the committee recommend the board award a contract for these services to Maxwell Lock and Ritter in an amount not to exceed $35,000.
Thank you, Ms. Greenberg. I have a motion by Ms. Greenberg. I have a second by Ms. Oliver. Open for discussion. Any questions, concerns? Ms. Oliver?
Super quick, who was our previous auditor?
Maxwell Lock and
Okay, yeah, okay, that's what I thought. I was like, okay.
Mr. Jones?
Yeah, do they, how do they rank in terms of the minority women business? Are they one of those that was considered?
So you can know whether they're a certified hub.
They are not a certified hub.
They are not.
Any other questions? If no further discussion, I would like to vote on the motion. All in favor?
Aye.
Any opposed? Any abstaining? I have 1 abstention from Manager Jones. Motion carries. Okay. Agenda item number 12 will be discussed in closed session. Discuss and take appropriate action on 1115 Medicaid waiver, delivery system reform incentive payment, DSRIP projects, the Community Care Collaborative, including its healthcare delivery arrangements and other community partnerships. I announce that the board is convening in closed session to discuss agenda item 12 under section 551.071 of the Texas Government Code, consultation with attorney, and section 551.085, governing board of certain providers of healthcare services. The committee is reconvening in open session. There will be no action on agenda item number 12. Agenda item number 13, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for August the 21st, 2019 at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas 78702. This time I'd like to accept a motion for adjournment. I have a motion by Ms. Greenberg, a second by Ms. Oliver. All in favor? Any opposed? Any abstaining? We are adjourned. Thank you. Appreciate it.
Thank you, members, for your time tonight.